Every 40 seconds, somewhere on this planet, someone suffers a stroke. By the time you finish reading this sentence, another brain has been struck. Each year, stroke claims nearly 6 million lives worldwide, stands as the second leading cause of death, and is the #1 source of permanent disability. The part that nobody states clearly enough: in a huge proportion of cases, the brain sends out very specific warnings hours or days before the major event. You just need to know what those warnings look like. If you want health information delivered in plain language with no theatrics and no sugarcoating, subscribe and tap like. We're pushing toward 100,000 subscribers, and you can genuinely help move that number. A stroke isn't simply, you were fine, you fell, you woke up in the hospital. In most cases, a stroke is the predictable culmination of blood vessels that have been deteriorating for years. If something is predictable, it's at least partly preventable. That's the entire point of this discussion. When people say stroke, they're actually referring to two very different events inside the brain. The first is a hemorrhagic stroke. A blood vessel within the brain ruptures. Blood floods into or around the brain, forms a clot that compresses brain tissue, and a significant percentage of those patients don't survive. The second is an ischemic stroke. The vessel doesn't tear, but instead becomes blocked. Blood flow halts to a section of the brain, and the brain cells in that area start dying within roughly 4 to 6 minutes. Ischemic strokes account for around 85% of all strokes. That's what I'm going to focus on today. To understand why every minute counts, you need a sense of just how demanding your brain really is. Your brain weighs about 1.4 kilograms, roughly 2% of your body weight, yet it consumes around 20% of the oxygen you inhale and roughly 25% of all the glucose circulating in your bloodstream. It's a command center that never powers down, and it requires an uninterrupted fuel supply. Cut that supply for even a few minutes, and cells begin dying in ways that cannot be reversed. That's why physicians describe stroke as a race against time. It's literally a race to rescue brain tissue before it's lost permanently. Most people miss what I'm about to say. For a brain artery to suddenly become blocked, the groundwork has usually been laid over years. The walls of the vessel have been damaged. Cholesterol and clots have been accumulating. The opening has been progressively narrowing. This is not an explosion out of nowhere. It's the final step in a long process. Along that path, your body typically sends out warning signals. The problem is that nobody ever taught you how to interpret them. In medical terminology, those early warning shots are called a transient ischemic attack, or TIA for short. Transient simply means temporary. It comes and it goes. Picture a carotid artery, the major neck vessel that carries blood from your heart up to your brain. Over the years, a fatty plaque has been forming on the inner wall right at the point where the artery branches. The opening gradually narrows. Then, at some moment, the already constricted vessel briefly spasms. Blood flow stops for a few seconds or a few minutes, and the brain region supplied by that artery essentially blacks out during that short interval. You see or feel a stroke symptom. Then the spasm releases, circulation returns, the symptom fades, and you assume you're fine again. What the research actually reveals is that a transient ischemic attack very often precedes a major ischemic stroke, typically within the following 72 hours. Those 3 days are your window during which catastrophe can still be averted. Most people don't use that window because the warning episode was brief, strange, and then disappeared, so they convince themselves not to take it seriously. These warning episodes usually last anywhere from about 30 seconds to maybe 10 minutes. That's precisely why they slip through the cracks. You could be in your kitchen, in the shower, getting out of a car, and by the time you stop to think about it, the symptom has already passed. But each of those episodes is your brain sending a final, unmistakable message. I am about to be in serious trouble. I want to walk you through the 5 major red flags and explain not just what they look like, but what's actually happening inside your body each time. Warning sign 1. Temporary blindness in one eye. You get up, head toward the kitchen, and suddenly one eye goes dark or hazy, as if someone pulled down a black curtain over that eye or smeared the lens with gray mud. You blink a few times, perhaps rub the eye, and within seconds or a minute at most, your vision returns. So you chalk it up to standing up too quickly or too much screen time. In reality, that curtain is almost always a tiny clot or a small fragment of plaque that broke off from the wall of your carotid artery, traveled upward, and briefly blocked the artery supplying the eye. The artery feeding your eye isn't some random, isolated tube. It's a direct branch of the internal carotid artery that supplies your brain. When the clot or plaque fragment wedges into that tiny eye artery, blood can't get through. The retina, the light-sensing tissue, loses its blood supply for a moment, and you see darkness or a blur instead of a sharp image. When the clot drifts away and circulation resumes, your vision comes back and you feel fortunate. You were fortunate because that same clot could have gone 2 millimeters in the other direction, into a brain artery. And then, instead of a 1-minute blackout in one eye, you'd be facing permanent loss of speech, paralysis of an arm and leg, or death. Doctors have a classic Latin name for that one-eye blackout, amaurosis fugax, which literally translates to fleeting blindness. Neurologists treat that term like a fire alarm. If a patient describes an episode like that, they receive urgent evaluation, because the risk of an actual stroke within the next several hours is significant. Hospital records reveal a pattern where a person dismisses 2 or 3 of these eye episodes, and the very next one is the major one in the brain. Warning sign 2. Sudden numbness or tingling on one side of your body. The medical term is paresthesia, but you can think of it as your skin behaving as if it's drunk. It might involve the entire arm, just the hand, half the face, or even one full side of the body. It feels like pins and needles, like cotton wool, or like that body part has turned to rubber. The key detail is that it appears out of nowhere while you're simply sitting, walking, or talking, lasts a few minutes, and then resolves on its own. You've probably slept on your arm at some point where nerve compression caused numbness that cleared up once you moved. That's different. There, your brain and spinal cord are fine. You pinched a nerve, and as soon as circulation and position returned to normal, sensation came back within a minute or two. With a TIA, the issue isn't in the arm. It's in the brain region that maps sensation from that arm, and the episode has nothing to do with how you were positioned. One more thing worth knowing. Stroke symptoms are usually one-sided because each brain hemisphere controls and perceives the opposite side of the body. When both hands go numb evenly, that more commonly points to neck-spine problems. But sudden one-sided numbness that resolves after a few minutes is a strong reason to get evaluated for TIA and stroke risk. Warning sign 3. A sudden loss of coordination. What people describe as a drunk walk without any alcohol involved. You're on a flat, familiar surface, and out of nowhere your foot lands in the wrong place. Your leg feels weak or rubbery, or you briefly stagger into the wall. Or you're hit by a sudden, intense spinning sensation that forces you to grab a chair or the door frame. Even though you weren't actually spinning, you didn't jerk your head, and you didn't just rise from bed. The part of your brain that keeps you balanced and coordinates smooth movement is called the cerebellum. It sits low in the back of your skull like a small auxiliary brain. It continuously calculates where your body is in space and how forcefully each muscle should fire, so you walk in a straight line instead of zigzagging. The cerebellum draws its blood supply from arteries that run up through the bones of your neck into the back of your head, what physicians call the vertebro-basilar system. If blood flow in those arteries drops sharply, even for a few seconds, the cerebellum essentially glitches. That's when you suddenly veer sideways, misstep, or experience violent dizziness for no apparent reason. In clinical practice, there's a pattern where people brush off these episodes as bad shoes. I was tired. Or, must be my blood pressure, and only discover later that those were cerebellar transient attacks. Benign dizziness usually has a clear trigger. Rolling over in bed, turning the head quickly, a known inner ear condition. But spontaneous, intense dizziness, combined with any trouble walking in a straight line, should be treated as a possible TIA until a doctor rules out a vascular cause. Warning sign 4. Sudden speech breakdown. Before we go further, I want to clarify something. If you occasionally can't remember your neighbor's name or you briefly forget the word for toothbrush, that isn't a stroke sign. That's a normal tip-of-the-tongue moment that happens more often when you're tired or stressed. What concerns neurologists is something quite different. When your speech suddenly collapses so dramatically that even you sense something is seriously wrong. There are 2 main speech areas in most people's brains, both typically located in the left hemisphere. One region, often called Broca's area, helps you form words and send clear instructions to the muscles of your tongue, lips, and jaw. When that region loses blood flow, you may understand everything people say to you, you know what you want to reply, but you can't get the words out. They come out slurred, fragmented, or stuck. The other region, often called Wernicke's area, helps you comprehend speech and organize your own sentences so they make sense. When that zone is in trouble, a person may speak fluently but say complete nonsense, like word salad, and may not understand simple phrases directed at them. If any of these speech problems appear suddenly and then fade after a few minutes, that's classic for a TIA, not, "I was just tired." You can't dismiss broken speech just because it's self-corrected. That's like your home alarm going off, stopping by itself, and you deciding it was probably nothing. Warning sign 5. Vitiligo combined with new, unusual headaches. This one is less obvious and surprises most people. Vitiligo, patches of pale or completely white skin where pigment-producing cells have stopped working, is an autoimmune process, meaning the immune system begins attacking your own pigment cells as if they were foreign invaders. When your immune system goes off target like this, it often doesn't stop at one organ. In many people, that same autoimmune process can quietly inflame the inner lining of blood vessels as well. That inner lining is called the endothelium, a microscopically thin layer of cells that coats the interior of every artery like an extremely smooth, non-stick surface. When the endothelium is healthy, blood components glide by and nothing really sticks. When it's damaged by inflammation, it becomes rough and scarred. Things start to adhere: cholesterol, platelets, various inflammatory proteins, forming the seeds of plaques and clots over time. Vitiligo alone doesn't doom you to a stroke, but if on top of that you develop frequent, unusually intense headaches that don't fit your usual pattern, that combination warrants a proper vascular workup rather than a wait-and-see approach. Headaches in general are tricky because many people blame damaged vessels when the actual problem lies elsewhere. A very common source of daily or frequent head pain is wear and tear in the small joints between the second and third neck vertebrae, essentially arthritis in the neck. That joint degeneration can irritate nearby nerves and send pain up into the head, which has nothing to do with a blocked brain artery. On top of that, many people carry an undiagnosed neck disc herniation, and if you never address it, in severe cases, it can threaten the nerve supply to your arms or legs. Headaches shouldn't just be numbed with pills over the long term. They need to be decoded with a doctor, especially when they change in character or pair up with other warning signs like the ones we just covered. Now I want to discuss what really wrecks your blood vessels from the inside, because this is where one of the biggest myths lives. The myth: my cholesterol is normal, so I'm safe from stroke. Stroke risk isn't just about what's floating around in your blood. It's very much about the condition of that endothelial lining on the inside of your vessels. Think back to that non-stick pan analogy. As long as the coating is intact, food doesn't stick. Once you scratch and damage it, everything starts sticking and burning. The first major enemy of the endothelium is chronically elevated blood sugar. Glucose is your cell's fuel, but to move from the blood into endothelial cells, it needs insulin, the hormone that essentially unlocks the door into the cell. When your body doesn't produce enough insulin, or your cells become resistant to it, you can have plenty of sugar in your blood, while the vessel lining cells are still starving. Starving cells become damaged, lose their shape, and can even peel away from the inner surface, leaving behind rough, scar-like patches. Those scarred zones can't contract properly when your blood pressure shifts. Doctors call that a loss of vasomotor reserve, meaning the vessel has lost its flexibility. And those rough patches are perfect landing pads for LDL cholesterol, platelets, and other blood components. Over time, these deposits grow into the plaques that narrow and stiffen your arteries. This process begins years before anyone officially tells you that you have diabetes. Even mild pre-diabetes, where your glucose is only slightly above normal, is enough to quietly injure the endothelium for a long time. The second major vascular enemy is smoking. Cigarette smoke contains thousands of chemicals, and dozens of them are known cancer-causing substances. But for stroke specifically, the concern is their effect on the endothelium and on the blood itself. With every cigarette, toxic compounds strike the inner surface of your vessels and cause direct chemical damage and inflammation. At the same time, nicotine and carbon monoxide make your blood thicker and stickier, increasing how easily platelets clump together and how readily clots form. When you combine a damaged, inflamed vessel wall with thick, sticky blood, you create ideal conditions for a clot to plug a brain artery. That's why smokers have roughly 2 to 4 times the risk of an ischemic stroke compared to non-smokers with similar cholesterol and blood pressure numbers. Blood pressure adds another layer of confusion because the myth here runs in the opposite direction. Many people have heard that stroke results from high blood pressure, so they're terrified of a high reading and relieved when the pressure is low or normal. Chronically high blood pressure absolutely is one of the strongest risk factors for stroke because, over the years, it physically stresses and weakens vessel walls and accelerates plaque formation. It's also the main driver behind hemorrhagic strokes, where a vessel literally bursts. There's a twist, though. An ischemic stroke often occurs not at the peak of blood pressure, but at a relative low point. Picture a brain artery that's already narrowed by more than half due to a plaque. It's like a water pipe that someone has squeezed in the middle. As long as the pressure in the system is high enough, some water still forces its way through that tight segment. But if the overall pressure drops, the flow through that narrowed point can decline to almost nothing, especially if a small clot becomes lodged there and the system lacks enough force to push it through. At night, while you sleep, blood pressure naturally falls by roughly 15 to 20%. This is a normal physiological dip, not a disease. If you already have a plaque-narrowed artery, that nighttime drop can be enough to convert a partial blockage into a complete one, especially if a clot has formed on that plaque while you were lying quietly. That's one reason some people go to bed feeling fine and wake up with stroke symptoms, or someone finds them that way in the morning. Age plays a role, but not in the simplistic, stroke is only for old people way you hear at family dinners. Yes, stroke risk rises significantly after about 50 and roughly doubles with each additional decade. In older adults, the dominant causes tend to be atherosclerosis, plaque buildup, along with long-standing high blood pressure and heart rhythm disorders. But about 10 to 15% of strokes occur in people younger than 45. In those younger patients, the records show different drivers: congenital vessel abnormalities, bulging weak spots in vessel walls called aneurysms that can rupture, clotting disorders, autoimmune diseases, and trauma to the head or neck. Another thing worth understanding: the speed of vascular damage from the same risk factors changes with age. After about 40, plaque buildup and endothelial injury from things like smoking, high sugar, or high pressure tends to progress about twice as fast as it did in your 30s. That's one reason doctors get more pointed about risk factor control as patients move through their 40s and 50s. So let me ask you something. How old are you right now? Your age changes how quickly your vessels respond to the same risk factors and shifts which causes of stroke are more likely in your particular situation. That really matters for what you and your doctor should be paying attention to. Now, the most practical part. What do you do if you've already had even one of those 5 warning episodes, even if it felt minor and disappeared in under 10 minutes? You have approximately 72 hours during which a great deal can still be done to prevent a full-blown stroke. The goal isn't to panic, but also not to waste that window. Stroke specialists often emphasize how important it is not to be completely alone after a suspected transient attack. This is worth planning ahead with your family and your doctor, especially if you live by yourself. If another, more serious episode occurs and you suddenly can't speak or move, you need another person who can witness it, call emergency services, and reach you quickly. Many people find it helpful to tell a close person what happened and ensure that someone can reach them easily over the following couple of days. That's a reasonable thing to bring up with your healthcare provider. Stroke guidelines also advise against driving yourself after a possible TIA. Losing vision or arm control for even a few seconds at highway speed is life-threatening for you and everyone around you. It's worth discussing in advance with your doctor what transportation plan makes sense in your situation if something like this ever happens, so you're not tempted to simply drive yourself in. Checking blood pressure is generally among the first steps in almost any acute situation. If you or someone near you can measure it, and the top number, the systolic pressure, is around 180 or higher, and the bottom number, the diastolic, is around 110 or higher, that fits the picture of a hypertensive crisis, not just elevated blood pressure. A crisis like that is itself a strong warning sign for stroke, and calling emergency services right away is what standard guidelines often recommend. Ask your doctor explicitly about this threshold, so you know in advance when to treat it as an emergency. One rule from stroke medicine is strict. Never start blood-thinning drugs like aspirin, anticoagulants, or similar medications on your own, based on a friend's advice or something you read online. There are 2 main types of stroke: ischemic, where a vessel is blocked, and hemorrhagic, where a vessel is bleeding. Thinning the blood can help in certain ischemic situations, but in a hemorrhagic stroke, it can make the bleeding faster and larger, which can kill a person more quickly. The only way to reliably tell the difference is with brain imaging, usually a CT scan in a hospital. No doctor can look at someone and be 100% certain which type is occurring without a scan. So instead of self-treating, the correct move is to get evaluated and let a medical team decide. You can absolutely ask your doctor in advance how they would want you to act if you ever suspect a stroke. While waiting for help or on the way to care, body position matters. Lying down is generally better than sitting bolt upright because it helps blood flow to the brain. Many clinicians suggest a comfortable flat position with the legs slightly raised above chest level to support circulation and ease the heart's work. The head should be neutral, not bent sharply forward and not thrown back, so that neck vessels aren't kinked. It's also wise to avoid smoking, alcohol, or exposure to hot baths or very hot showers in that moment, since sudden vessel dilation in an already unstable circulation can make things worse. Double-check this with your own doctor. Keeping a written list of all the medications you take regularly, stored somewhere easy to find, is a small step that can save precious minutes for emergency teams. Something many people get wrong. If 72 hours pass and no new episode occurs, that doesn't mean you're in the clear. It means you were given a second chance, and you still need to use it. There are 3 evaluations that are very reasonable to ask about at your next medical visit if you've experienced any of these warning signs. Each one looks at a different piece of the stroke puzzle. The first is a specialized ultrasound of your neck arteries called a carotid duplex ultrasound. Unlike a basic ultrasound that simply shows structure, duplex imaging shows both the anatomy of the artery and how blood is moving through it, including whether the flow accelerates and becomes turbulent at a narrowed segment. If the carotid artery is narrowed by more than roughly 70% due to plaque, doctors call that a hemodynamically significant stenosis, meaning the narrowing is severe enough to seriously impair blood flow. At that point, the question is less, will a stroke ever happen? And more, when will it happen if nothing changes? That's why surgeons may suggest a procedure called carotid endarterectomy, where they open the artery and remove the plaque. It sounds dramatic, but in modern practice, it's a routine surgery that saves tens of thousands of people from stroke every year. If you have risk factors or symptoms, asking your doctor about a carotid ultrasound is a reasonable conversation to have. The second test is a blood test called glycated hemoglobin, or HbA1c. This is ordinary hemoglobin, the oxygen-carrying protein in your red blood cells that has sugar molecules attached to it. The higher your blood sugar has been over the past several months, the more of your hemoglobin becomes sugar-coated. That's why this test reflects your average blood sugar over about 3 months, rather than just a single morning snapshot like a fasting glucose test. You can't game a good HbA1c with one perfect fasting result the day before the blood draw. It's especially good at catching that gray zone called prediabetes, where sugar has been high enough long enough to damage vessels, but nobody has labeled it diabetes yet. The cutoffs are clear. Glycated hemoglobin under about 5.7% is normal, 5.7 to 6.4% is prediabetes, and 6.5% or higher typically fits diabetes. If you've never had this test, or it has been years, that's an easy thing to bring up with your doctor, especially if you have any stroke risk factors. The third investigation is Holter monitoring of the ECG. In plain terms, a 24-hour heart rhythm recording. Instead of a 10 or 20-second electrocardiogram in the clinic, you wear a small device for a full day while you go about your normal routine. The reasoning is straightforward. Some dangerous heart rhythm problems come and go. They might appear once or twice a day for a few seconds and be completely missed by a brief snapshot ECG. The biggest rhythm culprit for stroke is atrial fibrillation, or AFib. In AFib, the upper chambers of the heart, the atria, stop beating in a steady, organized way and instead quiver chaotically, sometimes at rates of 300 to 400 contractions per minute. When that happens, blood doesn't empty smoothly from the atria. It churns and swirls instead of flowing. And in that swirling blood, clots form very easily. Those clots can shoot out of the heart, travel up to the brain, and lodge in an artery. That's called a cardioembolic stroke, and it tends to be severe. Many people with atrial fibrillation don't feel dramatic symptoms. At most, they notice occasional skipped beats, brief flutters, or they blame it on stress or caffeine. Holter monitoring is what catches these hidden episodes. If AFib is found, there are well-studied medications called anticoagulants, blood thinners, that, when prescribed and monitored correctly, can cut the stroke risk in this condition by roughly 60 to 70%. That's not an inevitable outcome. That's a risk you and your cardiologist can actively work on. Stepping back, stroke isn't a lightning bolt from a clear sky. It's a predictable event that usually arrives after years of silent vessel damage, and it often announces itself in advance. You now know the big ones: brief blindness in one eye, sudden one-sided numbness or tingling, abrupt loss of coordination or a drunk walk, sudden serious speech breakdown, and vitiligo combined with new, unusual headaches. Any of these appearing for the first time, even if they vanish within a minute, is a reason to talk to a doctor urgently and ask about those 3 evaluations: carotid duplex ultrasound, glycated hemoglobin, and Holter ECG monitoring. On the prevention side, there are things research links to lower stroke risk. Keeping blood sugar in a healthy range and catching prediabetes early protects the endothelium and slows plaque growth. Managing blood pressure with your doctor's help, not just pushing it down at all costs, but avoiding both extremes, reduces strain on your vessels and lowers both hemorrhagic and ischemic risk. Quitting smoking, with support if you need it, removes a constant chemical assault on your arteries and cuts your ischemic stroke risk by roughly a factor of 2 to 4 over time. And the most important point to internalize: don't wait for brief brain symptoms to resolve on their own. In the stroke world, you have about 72 hours to act. Here's what to do after this video. If you recognize any of the 5 warning signs from your own experience, even from months ago, write them down in plain language and bring that list to a doctor. Don't rely on memory. Ask directly whether you should be evaluated for transient ischemic attacks and whether carotid ultrasound, glycated hemoglobin, or Holter monitoring makes sense in your case. If you have risk factors like high sugar, high pressure, smoking, or autoimmune conditions, use what you learned here to have a more specific conversation with your doctor about stroke prevention, rather than walking away with "everything looks fine" and no actual numbers. Everything we covered today is for your understanding and education. Your situation is specific to you, and using this as a starting point for a real conversation with your doctor will always be more useful than trying to manage things on your own. If this made a complicated topic easier to follow, subscribe and hit like. And share this video with someone whose brain you'd like to keep working. That's not a small thing. I'm Dr. Dan Carter. Take care of yourselves. I'll see you in the next one.